of medication wearing off could actually be an indicator that your medication is wearing off. Bettina, is there anything that you find in particular that your symptoms return? When do you find that your symptoms return?
Pretty predictably around 11 in the morning, which is when my wake up in the morning dose wears off. And then in the evening, sometimes it's more difficult late in the day, 3 or 4 p.m., especially if there's a lot of stress when I'm working, I have a lot to do, then I find my symptoms start to come back pretty strongly.
Okay. And, you know, I think that most people start to identify certain timeframes that their medication are wearing off sort of in a predictable fashion. And that's actually fairly common, that they start to notice this reemergence of symptoms as they're due for their next dose. It's much more common to experience it on a regular and predictable basis before it starts to become unpredictable. But again, some patients, it can be sudden and unpredictable. And, you know, so certainly there are some people who experience these relatively sudden offs, which can be very, very challenging because they don't know quite when to expect it. And obviously it can be really difficult if you're engaging in activity where the medication's wearing off suddenly can create a lot of challenges. And so the other thing is that some patients actually have a hard time recognizing when the return of symptoms will begin, and they don't recognize it until it's really in that full return of symptoms, and they have this reemergence of those Parkinsonian symptoms. Other things are that it may not be as severe each time, and it may not last as long each time. And so a thing that you want to think about as well, and this is helpful to talk to the provider, is, are there usual times of day when you're experiencing symptoms? So Bettina, I know you and I have talked about this a little bit before, but how did you bring up the idea that you had symptoms that were reemerging or returning with your doctor?
I have a great relationship with my neurologist, and so he can tell if I walk into the office if I've taken my dose before or after, and he can see it. So I talked to him about needing something to smooth that out. It's just very challenging. But yeah, I brought that up with him. I did some research on my own, and we talked a lot about the different options and exactly how I was feeling and what part of the day I was feeling it.
Did your doctor ask you any specific questions about the return of symptoms or wearing off?
I think he asked me, what was I feeling? Like we were going through the list, was I tired? How long would that last? How much which part of the day was it happening? So you could figure out, do I need more medication? Do I need something else? So it was just in-depth questioning about based on that list that you had posted before, kind of what I was experiencing.
Okay, very good, thank you. So people can describe their return of symptoms differently. And again, you see one example here, a patient saying, I was at my granddaughter's recital and feeling really uncomfortable. So perhaps that restlessness. And the one below, I have to wait for my medication to take effect. It's hard because sometimes it works right away and other times it does not work at all. I get stuck. So those dose failures can be very, very challenging for people. And that lack of predictability especially can be challenging. You see some others here. The gentleman on the left says that I'm sitting at my desk and I'm okay, but when I stand up and my feet won't go. And so he experiences either some freezing or some significant changes in gait. You see one here that says, I can't walk well, I look like I'm drunk. And then the final one is feeling slow and noticing return of tremor. And so again, I think that there's a point to be made here, which is there are a variety of different ways in which this reemergence of symptoms can occur. But the other thing is that sometimes it's recognizing the non-motor aspects, just the feeling uncomfortable, that is also a challenge for people. And so sometimes that can be the clue that medication is starting to wear off. So Umbridge was developed because of this issue where people had unpredictability and needed something that could work as an on-demand therapy. It is used specifically to treat it off episodes. It's not something that is used in a regimented fashion. So it really is to enhance or supplement your oral medication regimen, and specifically for people who are treated with carbidopa, levodopa, or Sinemet. It's lightweight and portable, so it should be fairly easy to handle. And It comes in you have a little pouch even that you can carry the medication and the inhaler in. For people that have taken non-selective monoamine oxidase inhibitors, such as phenelzine or transcyclopromine within the last 2 weeks, they shouldn't use this medication, but they shouldn't be using carbidopa, levodopa either. You can see a picture of what the inhaler looks like and the capsules, and the dose is actually 2 of those capsules. You can see right there, it says the full dose is 2 capsules of the 42 milligrams. So Bettina, are you currently taking Umbridge?
Yes, I'm currently taking Umbridge. I take it once or twice a day. For me, it works in about 15 minutes, and we've talked about the fact that everyone is different. So I've had sometimes I experience nausea if I do it on an empty stomach, and I've had a little bit of a cough. But again, everyone's different, and you should talk to your doctor about the side effects that you're experiencing specifically.
Okay, thank you. So Umbridge is used as an as-needed therapy when symptoms start to return. And so that's one of the things to keep in mind. You don't want to wait until you're all the way off, but rather when you start to notice that the symptoms return. And in that case, for some people, as you had mentioned, for you, it takes about 15 minutes, Bettina, but for some people, it started to work as soon as 10 minutes. And the majority of patients experienced significant relief by 30 minutes and was still present at 60 minutes. And so this is something that works relatively quickly as 10 minutes, and does have a sustained effect over at least an hour. And what made this medication unique and really why it needed to be developed is something that I had mentioned before, which is that patients have variable responses to oral medication, and specifically oral carbidopa, levodopa. And there are a variety of reasons why that may happen. Things such as food can play a role, and specifically proteins can interfere with the absorption of levodopa. But there's also aspects of the disease itself that affect the stomach and may delay emptying of the stomach so that the medication can get into the first part of the small intestine to be absorbed. And so by developing something that can be inhaled into the lungs, it really bypasses those issues of the digestive tract and doesn't rely on that part of our system to actually absorb the medication. So the lungs have a tremendous surface area by which this medication can be absorbed, and can be absorbed rapidly, and then through that bloodstream gets into the brain itself. And so as in contrast, oral carbidopa levodopa has to move through the mouth, the stomach, and intestine before it reaches the brain. And remember that a substantial percentage of people with Parkinson's actually have some problems with their GI tract as part of the disease. And so it may be challenging to get the medication from the stomach into the small intestine where it can be absorbed. And so as a result, we can see delays in the effectiveness of the medication. And again, just to reiterate that foods that are high in protein can interfere with the absorption of levodopa. However, this isn't the case for everybody. So the time that it can take for oral carbidopa, levodopa can vary tremendously from person to person. And it can vary not only from person to person, but from one part of the day to the next. And so that variability can actually contribute to the return of symptoms, because people either have this, in this first graphic, you can see that there's this delay for the medication to work. In this one, we have this wearing off, and then the medication is taken and eventually it kicks in. And we see a variety of other patterns that can occur. And this is an example of sort of the worst case scenario, where someone takes a dose of medication and they may start to see a little bit of improvement, but that's an incomplete on, and they never really get much benefit out of that single dose. And then for someone who experiences a more rapid wearing off, that can be almost as if the bottom falls out. And in severe cases, that's actually a situation where in a matter of a few seconds, patients go from having their symptoms fairly well controlled to having reemergence of symptoms, which can be quite challenging. Just a few warnings about Umbridge. For patients who have asthma or chronic obstructive pulmonary disease or other lung diseases, this would not necessarily be the right medication, and that's something that you have to discuss with your healthcare provider. Be aware that Parkinson's medications, including Umbridge, can lead to things like daytime sleepiness, sleep disorders, drowsiness without warning, and of course the use of medications that increase sleepiness, such as antidepressants or antipsychotics, need to be discussed with your healthcare provider. There can be issues such as dizziness, nausea, sweating, or fainting when standing up. So these are people that may be having drops in their blood pressure leading to that lightheadedness or even fainting. Some people experience dyskinesia, so these abnormal involuntary movements. I think the poster child for that in some ways is Michael J. Fox. Although he's a sort of extreme example, there are certainly much more subtle and milder forms. Patients or people who have Parkinson's also are at increased risk for things like hallucinations and psychosis. We see depression as well in Parkinson's at an increased risk. Other things that people may experience that need to be discussed with the healthcare provider include things like compulsive behaviors, so urges like gambling, sexual urges, spending money, binge eating. And it's interesting that when you break those down, there's been some studies that look at those. Not to build upon stereotypes, but gambling and sexual urges are more common in men, and spending money and binge eating were more common in women. Glaucoma is something that needs to be warned. There is the rare circumstance, but it certainly has happened, and I've had a patient who's become pregnant while we're treating her for Parkinson's disease, and she was not on Umbridge, but it's not known whether Umbridge will harm an unborn baby. We know that in someone who's had a child and plans on breastfeeding, that levodopa can pass into breast milk, but the impact on that baby is not known. So Bettina, what else can you tell us about your experience with using the Umbridge inhaler?
Oh, my computer had an off period, so I switched computers, I apologize. So I take it, the first sign of symptoms returning, so I don't have issues loading the capsules in or anything. So I inhale, I hear the capsule doing that whirring sound, hold my breath, a few seconds, then let it out, and do the same thing with the second capsule. I practice with the inhaler. You just kind of have to get the hang of it. I have a certain speed that I like to inhale, and I kind of have my way of doing things, and it's pretty easy once you get into it, but you just have to get comfortable with the idea that you're inhaling powder. But it's something you can get used to pretty quickly.
Well, I think you made an important point too, which is that you are using it when you start to go into your off period and you can handle it fairly well, but they actually did a separate study that was a device study looking at people who are off in their ability to handle the device itself and manage to load the capsules into the inhaler, use the inhaler, and so on. And well over 99, there were over 600 people in that study, and well over 99% actually were able to manage the device and dose themselves appropriately. So that's one of those things that this is designed to try to be as simple as possible for people who actually do experience those off episodes and can manage it appropriately during those off episodes. So as Bettina had pointed out, where you see this circle here is really the time where someone should start taking this medication. And so when someone recognizes that they have their symptoms of Parkinson's starting to return, that would be the time where one may elect to use an on-demand therapy such as Umbridge. And again, each person should think about the specific return of symptoms. When would you use Umbridge? And I have some patients who say, well, if it's in the evening and I'm just going to be sitting in a chair, I won't necessarily want to take a dose, but other patients will want to use this medication often. The gentleman I saw yesterday actually uses 5 doses a day, which is the maximum number of doses per day per label. And he actually expressed that in some ways he wishes that he could take it more often. And for him, I've warned him, number one, it hasn't been studied, and number two, you will run out of medication because your insurance really won't cover it more often than that. So I'd mentioned the study previously that taking Umbridge as soon as you feel your symptoms start to return, 628 out of 629 people were actually able to use Umbridge when their symptoms returned once they had been instructed on how to use it. So it's a fairly simple process, but it does take some practice. Loading the capsule and then breathing and repeating. So the dose is 2 capsules, and people who experience these off episodes shouldn't take more than 1 dose for any off period, and again, not more than 5 doses per day. Bettina, what was your experience in receiving your first Umbridge prescription?
So I talked to my neurologist about it, and he called in the script. And then the specialty pharmacy called me, kind of went in a loop, and finally, by the time they got around to it, they sent it to me. But it was fairly straightforward, the standard for getting these. And I got a starter kit in the mail from Umbridge before I even got the medication. And there was a digital video card with instructions. And I'm someone who loves to read the manual before I engage in anything. It was very helpful, very clear, shows you how to use it. You could rewind and watch it again. That was very, very helpful.
And you make a very good point, Bettina, and that you had to actually speak to the specialty pharmacy for them to send you the medication, because that's one of the places where we sometimes hit a hitch, is that there has to be some acknowledgement that it's going to be sent. And again, for some practices, my own practice, we're actually able to take samples. And so I'm always happy to give my patient the sample in the office. And if there's a time that's appropriate, we actually encourage them to even use their first dose of medication in the office, so we can talk them through that process. But we use the videos like you had mentioned. And so each setting as far as practices are a little bit different, but it is something for me as a physician and someone who treats a lot of people who have Parkinson's, it's actually quite rewarding to watch that aha moment that happens with some people, that they can feel their symptoms starting to subside fairly quickly after taking the dose of Umbridge.
I want to say one more thing about the kit. There's a phone number in there, an 800 number. And when I first started taking the meds, I thought, well, I'll just call and see if they can help me out, if they have any tips. I called them, the Umbridge folks called my neurologist and talked to them, and then talked to their own pharmacist and called me back a couple of days later, like, how was our advice helpful? How are you taking it? Is this good? So that was reassuring too. There's someone on the other end of the line that was there to help.
Yeah, and actually your timing was perfect, because I had switched slides. So there's the prescription support services, and they are there for people who want to use this medication, so they can help not only with how to use the medication, and they will follow up with you, but also having that understanding of insurance coverage, because that can be one of the challenges that people experience, because this is something that comes from a specialty pharmacy. And if you haven't had a medication that comes from a specialty pharmacy, it can be a little bit challenging the first time you go through that experience. There's also help available online. So in Umbridge.com, there's a demonstration video there as well. So the video that Bettina had alluded to actually is available there, so that it sometimes takes a little bit of practice and more than one try of using this in order to get it right. And people develop their own little tricks that work for them in the process. And so you can go there and sign up to receive additional information, and there's patient leaflets and so on. So just a little bit of other safety information. If you're taking any of these medications, so MAOB inhibitors, so the medications that are on the market currently are Xadago is a branded one, what used to be Azilect, Rasagiline, and Selegiline are MAOB inhibitors. Dopamine antagonists, which typically we try very hard to stay away from in people with Parkinson's. And so those are things like the phenothiazines and metoclopramide, which are used for treating nausea oftentimes. Then risperidone, which is an antipsychotic. Isoniazid, which unless you have tuberculosis, you're probably not using. Iron salts or multiple vitamins that contain iron salts. And then, of course, when you're using Umbridge, until you know how the medication affects you, you have to be aware of those issues that I had mentioned before, including the potential for sedation and suddenly falling asleep. And so you shouldn't operate heavy machinery or do other activities where you would be potentially at risk if you were to fall asleep suddenly or unexpectedly. And again, if you experience any of these side effects, like falling asleep during normal daily activities, having signs of withdrawal, which include things like stiff muscles and fever, and this can occur in theory if you suddenly stop using Umbridge or carbidopa levodopa, or if you were to suddenly lower your dose of those medications. Signs of low blood pressure, such as dizziness or lightheadedness when standing up, if you faint, and if you start to experience those symptoms, certainly they should subside if you sit back down, but certainly be aware about getting up slowly after sitting or lying down. And I had mentioned the idea of hallucinations and other psychosis before. Any medication that is dopaminergic has the potential to aggravate those symptoms. Continuing on, I had mentioned the uncontrollable urges or impulse control disorders. Dyskinesia was also something that we can see. And again, this is something that we see with Parkinson's medications in general, but it may be such that dyskinesias are severe enough that one would need to stop Umbridge or other medications in order to manage them. More concerning to me as a provider are people who have asthma and COPD, where they start to develop bronchospasm, increased eye pressure in patients with glaucoma, and so this is something that needs to be monitored. And then changes in lab values like liver tests, although there is no guidance regarding the need to actually monitor liver function or liver tests while on this medication. So Umbridge is used to treat the return of symptoms, and it can be used and should be used as soon as you start to feel your symptoms return. It has this unique inhaled delivery, which again avoids some of the complicating factors of the gastrointestinal system in Parkinson's disease and bypasses that pathway. And as a result can start to work as quickly as 10 minutes. And again, it's self-administered, it's lightweight, and it's portable. As a reminder, I'd mentioned this before, it does not replace regular oral carbidopa-levodopa. And you can see some of this additional safety information listed here. So if you are someone who is experiencing wearing off or return of your symptoms, Umbridge may be an option for you. And I think the key in having that discussion with your doctor is identifying what symptoms you have, what are the signs that you're having wearing off or return of your symptoms, when do they occur? And sometimes it can be challenging because one of the things that we'll see is I'll have patients sometimes tell me that they find that as soon as they've taken their dose of medication, they start to notice that their symptoms get worse. And oftentimes what that really means is that before the dose of medication that they've taken has started to work, because the average time that an oral dose of medication takes to work is about 45 minutes. And of course, there's variation around that. And so there are some people that it works much faster, and there's some that it can take twice as long. But what that means is they're wearing off before that next dose starts to work, how long those symptoms last. And of course, as I had used the example before, my patient who says they like to, they sit in the chair in the evening and they don't need to use a medication like Umbridge, but how disruptive those symptoms may be. And if you're experiencing some of these issues with return of symptoms and they are bothersome to you, then certainly discussing the possibility of using Umbridge with your physician would be appropriate. So I'm going to stop here and thank all of you for your participation. And I think we're ready to open the floor to questions.
Yes, thank you, Dr. Ellenbogen. So at this time, and I really do encourage you, if you have any questions regarding any of the information that Dr. Ellenbogen has presented with us today or Bettina has shared, just go to the chat bubble because we have so many participants. We weren't going to unmute the lines and out of fear of it just kind of being a little over noisy, but if you circle around either at the bottom of your screen or at the top, there should be a chat that pulls up, and click on that and you can type in a message and I will convey that over to the doctor and he can address that for you. So please take a few moments right now to have any questions that you may have on your mind answered. So
Kurt, I want to say one thing in closing, that this Parkinson's is a long road and you don't have to feel sick all the time. Like if you're worried, if you're not feeling good any of the time of day, if you're feeling crummy, just, you can get help, talk to your doctor. There are a lot of options. So just want to let you know, it's not this is something you can live with and manage, and there are options for you. So definitely talk to your doctor about any medications or treatments or exercise, because you can live a good life with this. So.
Absolutely.
Thank you.
And you're right, it is a long road. It's a marathon, not a sprint.
So doctor, we have one question that's in here that's come in. It says, I have asthma and I'm experiencing off time with my current medications. Are there any other options other than Umbridge?
Well, there are other ways of addressing off episodes, and there are a variety of things that can be done. Just modifying your own personal regimen, depending on your asthma, you may or may not be appropriate for someone for a treatment like Umbridge, and that would be something you would want to discuss with your own physician. But with your own treating physician, I think you can certainly have a discussion about when you're having your off episodes and what strategies you may be able to adopt in order to best manage those. And there are really a lot of things that can be done. And so it's just trying to individualize that approach for you. And this is not the only treatment option that exists. And so if given your asthma, this isn't the right treatment, then there are certainly other things that can be done.
Another question that's come in is, would Umbridge help with freezing when it occurs?
Well, that's a tough question to answer specifically, in the sense that freezing can occur for some people even when they're on. And so in the individual that, in the individual who actually has freezing as part of their off episodes, then yes, I do expect it to help. And about 80% of individuals have freezing principally as an off symptom versus those who experience it on freezing. And so on freezing, I would not expect it to help. So freezing when the medication seems to be working. But if it's part of those off episodes, then I would expect it to help, just like oral levodopa would help in that situation. This is just a more rapid way of addressing it.
Very good. And if at any point when Dr. Ellenbogen's explaining the information, if you want to hear a little bit more about it, or if you didn't touch base specifically, please just, resend again. Dr. Ellenbogen, we have another question. This one's on the lines of, why wouldn't you just change the standard carbidopa-levodopa dosing interval?
Well, so that gets to the point that I was making about people who have predictable offs versus people who have less predictable off episodes. And so that in some cases, if a person's on 3 times a day levodopa, carbidopa-levodopa, or 4 times a day, and they predictably wear off between doses, they know a half hour, 45 minutes before their next dose, they start to experience the signs that their medicine is wearing off, then we may change their regimen. So that's one option. But there are others who don't have that same predictability, and this provides that additional tool for individuals to have in order to address those off episodes that occur a little more unexpectedly or a little bit more suddenly. And so that's why there's such variability. In the studies, people were allowed to dose up to 5 times a day. And in practice, as I'd mentioned, I do have someone who does dose 5 times a day, but much more commonly, I have people who dose once a day, twice a day, or sometimes even a handful of times a week, because they're picking and choosing those off episodes that are important to them to treat. And so that's really why we use a medication like this as an on-demand therapy in support of that oral regimen that individuals are taking. The other example that I would give is, and we actually did a study that's been published looking at people who have morning off. And so people who wake up with their symptoms in the morning, and again, it takes some time for the oral medication to kick in. And so I have patients who actually jumpstart their day by taking a dose of Umbridge at the same time they take their oral medications. And for some of those patients, it really does seem to get them on a little bit more quickly, and that can help with it. Other examples where, again, maybe not adjusting the regular oral regimen, I have patients who will use this sometimes at night. And patients who get up, they go to the bathroom. When they come back from the bathroom, their medication is essentially worn off. They have tremor or other symptoms that keep them from being able to get back to sleep. And by using a dose of Umbridge, they've actually been able to manage those off symptoms, and it provides enough relief that they're able to get back to sleep. So just a few ways that it can be helpful beyond just managing oral dosing.
Excellent, thank you. So I'm not sure, but on this question, but it says, what can be done, if anything, for on freezing? So I'm assuming whoever wrote this, and again, I won't, I don't say any names, but are they referring to that they're having a freezing episode, but they still feel like are in an on state, I guess?
Well, because again, people can experience freezing episodes in an on state. And that's where some of the strategies that are taught in big therapy and some of the other therapies for Parkinson's disease can be really helpful. And it's sometimes even just quite honestly mind over matter. And so walking for us, once we hit about 1.5 years of age, becomes a natural process. And it really becomes something that we don't think about. But when you start to think about gait, so it's an automatic behavior. And Parkinson seems to affect that automatic behavior, whereas when we ask people to do things that are a little bit unusual, so marching, for example, or even running, patients can do those without experiencing that same impairment of gait, whether it's freezing or some of the other things that we see. And so in that sense, it becomes mind over matter because you are bypassing that automatic behavior and doing something that's not automatic. Similarly, if you've seen something like the U-Step walker that has a laser device on it, that laser serves as a visual cue for you to step on or over. So giving that visual target as opposed to just trying to take a natural stride will also make a difference. And so it's not necessarily something that is medication that's going to treat that freezing that occurs during the on state, but it's some of those other strategies that can be helpful.
Excellent, thank you. Again, I'm going to give a few more minutes. I don't see any other questions in the queue now, but if anybody has any other questions or follow-ups to what the doctor has been answering, please use the chat feature.
Kurt, this is Mary Sue. It might be a good idea if I unmute people. Some people have a hard time maybe with the chat feature.
Okay, I think, yeah, if people have had an opportunity to use the
Yeah.
feature, but they want to, verbalize it, yeah, okay.
Okay, I'm going to unmute everyone. So if you have a question, go ahead and ask. Not really hearing anything.
All right, so we'll give one last round. If you do have a question that you would like to verbalize and ask Dr. Ellenbogen, please feel free to just speak into your device.
I think we're probably done.
Yeah, okay. So if there are no further questions, I want to thank everyone for taking time this evening to join our program. Please continue to stay healthy and safe out there. And at this time, myself, Bettina, and Dr. Ellenbogen are going to leave the program. And Mary Sue, you will be able to take control for anything after the follow-up. Have a great rest of the day, everyone. This concludes the presentation. Thank you.
Everybody, stay safe and stay well.
Thank you. Thank you.
Thank you.